I suggest you spend some time together on vertigo surgery. It is difficult surgery that is rarely performed and is mainly used in tertiary care centers, in expert centers. We will focus on two diseases. The first, Meniere's disease, to which we can associate delayed vertigo, and the second would be the Meniere's disease, or more precisely, the third mobile window syndrome. Management of Meniere's disease has evolved significantly over the past 30 years. What is certain is that you should not take the elevator but take the stairs, which means that you must take a step-by-step approach while trying to preserve the vestibular function as long as possible. It's a key message. There have been some very interesting publications over the last 2 years, including one which takes stock of the use of surgery in Meniere's disease. What is progressive, in fact, are medical treatment, and in particular treatment with antihistamine and diuretics. On the other hand, surgical treatment are used less and less. And they act as surgery, although it recognizes a renewal or labyrinthine destruction. This is a chart that is clearly nice because you see very well how the oral medication are increasing with time from 2008 to 2022. You see that intratympanic injections are quite stable, in fact. And endolymphatic sac surgery are a lot decreased from 18% to 6%. A drop, real drop. And labyrinthectomy has become very rarely practiced, in fact, on 0.2% now. So everyone knows the diagnostic criteria for the Balinese Society. I won't go into them again. What is important to me is to make the diagnosis of eye drops. And nothing is easier using multi-frequency tympanometry with a Gratian-Stadler tympanometer. It allows you to visualize the conductance at 2 kHz, which is characterized by 2 humps, like in the camel. When the bumps are more than 235 DAPA apart, you are sure that there is an eye drops, sure. And it takes 2 minutes to perform this test. So use it, because it's much easier than performing an MRI examination and less costful. So this recent publication, both Greek and German, in Journal of Clinical Medicine, clearly shows the power and the reliability of this technique as we have described it 20 years ago now. Some perhaps remember during the World Congress in Paris in 2017, I chaired a round table to try to draw an international consensus on the treatment of Meniere's disease. There was Jérôme Neveu from France, Maurizio Barbera from Rome, Italy, John Donhofer, William Gibson from Australia, Kitahara from Japan. And we agreed, in fact, on some basic statement. First, lifestyle counseling, household diet screening, all that's very important to be sure there's not sleep apnea. Pestahistine diuretics, then grommet, then pressure post-treatment in countries in which it is realized. At this stage, 80% of patients are cured or in remission. If it doesn't work, you perform a local conservative medical treatment with intratympanic steroids, above all dexamethasone. And if it doesn't work, you have to differentiate between a good hearing or a bad hearing. If the hearing is good, you use a conservative surgical treatment like sac surgery. And if the hearing is poor, you prefer a local destructive medical treatment like intratympanic gentamicin. So, if the intratympanic gentamicin is not efficient and the patient is dead, has a dead ear or quite dead ear, you perform a laminectomy, that is to say, destructive surgical treatment. On the other end, if you have performed a conservative surgical treatment like a sac surgery, and the patient is not well, you go to a destructive surgical treatment, but preserving hearing, a vestibular neurotomy. So what we do schematically in France, we give betahistine 2, 24 milligram 2 to 6 times a day, a salt diet, and we use routinely psychotherapy. If it doesn't work, we give glycerol syrup or both from time to time, acetazolamide as a diuretic, which is, in my opinion, the more efficient. If it doesn't work, we perform intratympanic steroids. If it doesn't work, it's depending on the hearing. If the hearing is good and the tympanometry shows an eye drops, we perform a sac surgery. If it doesn't work, a neurotomy. In case of a poor hearing or no eye drops at tympanometry, we perform a gentamicin treatment, intratympanic gentamicin. And if it doesn't work, as the hearing is poor or there is dead ear, we go to surgical laminectomy. Very special is when the patient has traumatic crisis, drop attacks. If he has drop attacks or she has drop attacks, we go towards destructive treatment like either neurotomy or gentamicin depending on the hearing. So first, let's talk about sac surgery. I want to insist on the fact that you have to preserve the sac and not clip it. Gibson have very well demonstrated that in animals, when you clip the sac, you induce an eye drops. So, in fact, when you increase the eye drops, you kill the ear. Of course, if you kill the ear, the patient is cured. So, much better to preserve the sac in size or give steroids inside. Sac surgery is now central in the Japanese recommendation written in 2021. You see the anaphylactic treatment after pressure pulse treatment, which is very used in Japan, and of course conservative treatment. And you go to selective destruction of the vestibule with intratympanic gentamicin or vestibular neurotomy if endolymphatic sac surgery is not efficient. And they use endolymphatic sac surgery with injection of dexamethasone inside, like I do. So let's go now to see the surgical technique. So let's go now to look at the technique. You have to locate the fascial level mastoid portion. You have to locate precisely the posterior canal. Then you drill behind the facial nerve and you drill just caudal to the posterior canal and you expose the endolymphatic sac, which appear like thickened dura with whitish with vessels running on its surface. So of course mind to the posterior canal and mind to the facial nerve. So you continue drilling in the direction of the jugular bulb, and when you have removed the bone covering the sac, you can incise it to expose its lumen. If you operate on the young Meniere's disease, the lumen is clearly identified. That's why under-refractive surgery is more efficient when the hearing is good and the disease not too much evolved. After having incised the sac and exposed its lumen, you have to inject inside gently dexamethasone. And after you have injected it, you put pieces of gel foam inside the cavity to maintain the dexamethasone in position. You can elevate the dura to be sure you have put in the sac sufficient quantity of dexamethasone. Of course, you avoid sucking in the sac. We can say today, as our Italian colleagues say, that the surgery recognizes new life for an old technique. Yes, old, because described in 1924 in Bordeaux. And a recent publication for the Munich school, very serious school, clearly highlights the effectiveness that has now been demonstrated. We remember that it was often and for a long time seen as a placebo surgery, which recent work denounces. So we have a good tool with us, and we have to use it in case of a young Meniere's disease in which the treatment, medical treatment, is not efficient. But in case of drop attack, don't wait for an efficiency. Drop attack is dramatic. See this patient, which is falling dramatically without possibility for him to avoid it. And of course, it can be hurted. So let's speak now of vestibular neurotomy and look at his technique. This is a vestibular neurotomy performed on the right side in a patient who has a sclerotic mastoid. With a retrolabyrinthine approach, that is the approach I prefer. It is an orthologic approach, not a neurosurgical approach like vestibular neurotomy with a sub-occipital or retrosigmoid approach. So you locate the posterior canal, you incise the dura just behind. You don't put any push on the sigmoid sinus to expose the dura just behind the posterior canal. We see at the anterior part of the surgical view the jugular bulb. You be very cautious in your decision and dissection of the dura to avoid jeopardizing the vessels of the posterior fossa, especially the veins and the artery, because the arteries are very critical, and if you bless it, if you hurt it or cut it, you have an hemorrhage and the risk of brainstem infarction. Then, facing the vestibular nerve and the cochlear nerve, you cut the superior part of the eighth nerve, the vestibular nerve, every time looking at the fascia nerve, which is situated just behind. So progressively, gently, you cut fibers of the vestibular nerve and progressively appears the fascia nerve and the intermediate nerve. When you see this nerve, your job is finished. Journal is a very nice publication of the teams of France in France in Journal of Neurosurgery in 2022 about 74 patients treated over 10 years of a Meniere's disease by a vestibular neurotomy, a retrosigmoid vestibular neurotomy. And they observe 20% of cure, no post-op hearing loss, and only 3 CSF leaks. Personally, I prefer the retrolab approach because the CSF leaks are quite absent with this approach, which is an ontologic approach and not an neurosurgical approach. Recently, Salvinelli and collaborators published the results of selective vestibular anatomy, realized with the same approach that I showed, and that is to say, a retrolab approach. So there are teams now, more and more teams that use retrolab approach when they are ENT surgeon or neurosurgeon. And it is a recent publication in 2024. So, of course, you can use vestibular anatomy in case of delayed vertigo, but in case of delayed vertigo, usually the ear is dead, and the best way to cure the patient is to perform a labyrinthine destruction. So you can destroy the labyrinth going through the mastoid, in drilling the 3 canals, then opening the vestibule. It's complete destruction, no discussion, of course, but you can perform more simpler using a transmeatic transoval labyrinthine destruction I prefer personally. So, transmeatic approach, opening the middle ear, locating the polar tympani, then the ossicular chain, then you open the attic in the scutum with a drill to try to preserve as much as possible the corner tympani. You can reroute it using a hook to remove it from its bony channel, like this, in order to enlarge the surgical field. Then you separate the incus from the stapes. You try to remove the incus if possible. If not, you push it in the attic. Then you remove gently the stapes. It's quite difficult for otologists which try to improve the hearing to do this, but it's a good exercise, especially for the resident to do this without breaking the stapes. So you cut, of course, the tendon, then you remove the ossicle from the oval window. You have opened the vestibule. Empty it, then you drill between the oval window and the round window. The drill, the rotation of the drill is anti-clockwise to avoid the drill going in the fascial nerve just above. Progressively you open largely the vestibule. Then when you are finished, you put some fascia inside, not to let the vestibule open in the middle ear. In case of infection, it might be dangerous. So you fill it completely. Of course, with the hook, you remove the sensory neural epithelium. Here. teams, especially in France and especially in Strasbourg, have described partial labial fan destruction opening only the lateral canal. Because the lateral canal is responsible for the majority of the rotating, of the spinning sensation. Of course, the lateral canal is the leader in this sensation. So it's rarely performed, in fact, because I prefer performing a total destruction when the hearing is correct. But when you have severe bilateral Meniere's disease, you don't want to destroy both ears, of course. You can, it's a real problem. You can do this and the patient will be cured of its spinning vertigo. And if you are cautious, the hearing is not dead after. So opening the canal, filling up the canal with piece of fascia, like when you perform surgery of supercanal dehiscence. So you put apart a piece of fascia, then you push it inside the lateral canal. And so on, another piece, and so on and so on. Let's go now to the third window syndrome. The third window syndrome is now a fashionable disease for surgeons. However, in my opinion, we must tie our hands behind our backs before operating on this patient. and explore them well and listen to them before making a surgical indication. So the criteria have been very well described by a word in Journal of Vestibular Research in 2021. I insist on this. At least one of the following symptoms consistent with the presence of third window: bone conduction hyperacusis, sound-induced vertigo and or synopsia time locked to the stimulus, pressure-induced vertigo and or synopsia time locked to the stimulus, pulsatil tinnitus, and at least one of the following diagnostic tests indicating the third window, mobile window in the inner ear: nystagmus characteristic of excitation or inhibition of the affected canal, evoked by sounds or by changes in medullary pressure or intraocular pressure. Low frequency negative bone conduction threshold on putal geometry. Enhanced VAMPs responses, very critical. HRCT imaging demonstrating, of course, the dehiscence of the superior semiconductor canal, and not better accounted for by another vestibular disease or disorder. So the clinical examination is particularly important. We must endeavor to find an upper side with finger tympanometry, and you observe a movement of the eye, a vertical movement with a rotation of the eyeball. The same here. You see, when you push your finger in the ear canal, you obtain a movement of the eye which is not a nystagmus in fact, but a movement in the vertical and rotational position. And you can perform also an Almaghi sign, which consists of the perception of the ear, in the ear, of the vibration of a tuning fork placed at the ankle or at the level of the elbow. Also, I recommend doing a vibratory test at 100 Hz to look for a vertical nystagmus induced by the vibratory test. But for me, the key exam is or are the C-VAMPs. You observe an amplitude increase and the threshold decrease. It's more sensible with tone burst and more sensible at 4 kHz. In my team, we perform only at 4 kHz to avoid performing numerous stimulation at 100 dB, which are not appreciated by patients with third window. And when you operate in patient, you observe that these C-VAMPs are normalized in post-op. But above all, mind to vestibular migraine. And I like really the paper of Smetak in Neurology 2022, this author tells us the symptoms of migraine confirm those of SCDS, and unrecognized or undertreated migraine may contribute to surgical failure in SCDS, and I have observed this. Therefore, we recommend a high index of suspicion of migraine in patients with SCDS and a trial of medical therapy in the setting of suspected migraine. So finally, what do we do? Diagnosis with clinical symptoms, word criteria, C-VAMPs, O-VAMPs, and so on and so on. Assess disability. Some patients are not very disabled, others are very disabled. Bilaterality, which complicates the surgery. We locate the position of the third window. Some are easy to reach, others no. Then we look systematically for a fourth mobile window. If the patient has migraine, we give first treatment of migraine with amitriptyline or beta blockers. If there is no migraine, the patient is very dizzy, we go to surgery. The patient is not very dizzy, we wait. So to operate, we have some solution. The first one, historically, is a middle fossa. Personally, I use a middle fossa without any retractor, like in here, with cotonoids pushing the dura. So the dehiscence appear to your eyes. Then you have to close the canal with bone wax or temporalis fascia, as you want, as preferred. Then you put a piece of bone pâté to complete the closure and to protect the dura around. Though this was the original technique, I used it during 10 years. Then, as a lot of authors, I switched to perform a transmastoid approach. So, right here, lateral canal, the loop of the superior canal, you blue line the canal. Now, it's not an easy surgery because you have to locate the temporal fossa dura, posterior fossa dura, and not to jeopardize it. And when the lumen is exposed, when the blue line is exposed, you open the canal and you push inside a piece of fascia. One piece of fascia or two pieces of fascia, depending on your technique you prefer. One piece of fascia just posterior to the ampulla, one piece of fascia at the level of the crus cumen. Avoiding suctioning inside the lumen, of course. Then what is critical is to put a large piece of bone, bone substitute, to fill up completely the mastoid, to avoid the patient keeping some hyperacusis. There is another technique which is elegant but not very effective, is to cap the superior canal, not entering its lumen. It was described by Lundi in 2011. In the left ear, you have located, in fact, the lumen, the blue line of the canal. Then you insert, after elevating the dura from the superior aspect of the petrous bone, you insert a piece of cartilage and perichondrium to cap the lumen of the superior canal. So you wait for the same effect than the middle fossa, but in fact the effect is less effective, and prefer opening the lumen. So, when you have, in this situation, a superior petrosal sinus at the contact of the lumen of the superior canal, of course, the better is to perform a middle fossa approach, transmastoid approach, of course, sorry. But in other situations, the better is to reinforce the run window. By example, here, when you have the third window between the second turn of the cochlea and the labyrinthine portion of the nerve. So you can have another window between the tympanic portion of the facial nerve and the lateral canal, not here, but here, yes. So if you compare this, which is normal, and this, which is abnormal, you see it's possible. You can have also a third window between the jugular bulb or the vertical of the jugular bulb and the posterior canal. You can have also a third window, mobile window between the endolymphatic sac here and jugular bulb. You can have a third window between the dilation of the vestibular aqueduct and the posterior canal here. And in this case, the best way to treat because you have no way to separate the facial nerve, of course, from the vestibule, is to close the round window. This technique is not as efficient, of course, but the patient has less hyperacusis. And I think it's a good technique when the hyperacusis is very disabling. So you put a piece of fascia on the round window, then you insert a piece of cartilage like this, and then the round window is reinforced, not closed, but reinforced. And I think it's a good way. So thank you for listening to this course about surgery of vertigo. I hope it will help you in your practice. Thank you for hearing.